Hello everyone. So today we are going to start with the topic called as jaundice, which is a prominent topic in pediatrics. Actually, we are not going to cover neonatal jaundice, that is jaundice below 28 days of life. We are going to go with the jaundice in a child. So what is jaundice? What do you think? What is jaundice? Okay, so we'll start now. Jaundice is the yellow discoloration of skin, sclera, and mucous membranes due to elevated serum bilirubin level that is more than 2 milligram per deciliter. So TSB should be more than 2 milligram per deciliter. Then approach to jaundice in a child. So always classify based on age of the child and type of bilirubin. And also you can do a bit classification based on duration and associated symptoms with that particular jaundice. So classification. Then the classification is actually based on age. Major classification is based on age and based on type of bilirubin. So based on age is neonatal jaundice, that is uh, below or equal to 28 days of life. So whatever jaundice that happens within 28 days of life is known as neonatal jaundice. And the jaundice in infants and children, that is about 28 days to 18 years of age. So you can go till adolescence too. Then based on bilirubin, type of bilirubin. So we have unconjugated, that is indirect hyperbilirubinemia, and conjugated, that is direct hyperbilirubinemia. So we'll go with the type of bilirubin, okay? Because age related is not our case concern today. So by the type of bilirubin, it is unconjugated, that is indirect hyperbilirubinemia. So what are the causes? Major causes: hemolysis, that is breakdown of RBC. So hemolysis, then any hemolytic anemia, so in which RBCs are broken down and thus causes decreased oxygenation of the blood, leading to anemia. Then some genetics deficiencies like thalassemia, major, minor, and G6PD deficiency. Then we have Gilbert syndrome and Krigler-Najar syndrome, and ineffective erythropoiesis, that is formation of RBCs. And what are the features? So this is very important. Because of this, you can definitely identify what type of bilirubinemia is present. Uh, so normal colored urine and no clay colored stools and no pruritus. So you can understand. So why is normal colored urine and no clay colored stools, that is normal stools, are observed? So in unconjugated hyperbilirubinemia, the conjugated bilirubin is still released via bile duct into the intestine. So there is no liver pathology. Therefore, the normal uh, stool and urine is presented. Whereas we have conjugated, that is direct hyperbilirubinemia. The causes are wisely three, was three: hepatocellular, that is regarding to the liver, parenchymal. Then that is viral hepatitis, that is hepatitis A virus, hepatitis E virus are the most common observed virus in children. Then we have drug-induced liver injury. So ATT and paracetamol are famous drugs which are known to cause hepatotoxicity. Just remember the paracetamol and ATT because that is very important. Then autoimmune hepatitis, that is genetic. Then uh, then we have cholestatic and obstructive, that is obstructive jaundice. So it is because of biliary atresia in infant. So the bile duct is constricted in that. So bile is cannot, like, if this is normal, it becomes like this, or maybe sometimes very weird, and it is the lumen becomes very narrow. Then choledochal cyst present in uh, uh, gallbladder. Then gallstones. Then we have metabolic causes. So we have Wilson's disease, that is copper accumulation. Then alpha 1 antitrypsin deficiency, which is also present in uh, emphysema. Then the features of conjugated hyperbilirubinemia is dark urine, clay-colored stools, and pruritus and hepatomegaly. Dark urine and clay-colored stools. So conjugated bilirubin does not go inside the intestine. Thus, and other further circulation. Thus, there is a lot of dark urine and clay colored stools. Then pruritus. So pruritus is itching of the skin, inflammation of the epidermal layer. So you can have rashes present, and hepatomegaly, that is organomegaly, that is uh, increased size of liver. Then we have see. So theoretical knowledge is what you can get through books, but here we'll go also with the practical knowledge. So here we have history taking regarding the jaundice. What are the presenting complaints? So presenting complaints, most important and most observant complaints are yellow discoloration of skin and sclera. Why sclera? So sclera has elastin, and elastin and bilirubin actually binds very well. So therefore, you can get presentation of jaundice very quick in your sclera. So yellow discoloration of skin and eyes, and also mucous membranes. Then fever, abdominal pain, fever because if there is any viral cause, like we have studied here, hepatocellular, that is most common viral hepatitis A and A and E. So then we have vomiting, loss of appetite, pruritus, pale stools, and dark urine. So if a child presents with this in your OPD someday, it is definitely most likely diagnosis is going to be jaundice. Still, the definitive we have to go by investigations. History of presenting illness. So what? So what you have to check is onset, duration, onset, that is duration, and progression of the jaundice, associated fever, that is just viral hepatitis, drug intake, that is we have learned paracetamol and ATT. Also, some herbal medications are can cause hepatotoxicity. Then blood transfusion can be a reason. Then travel and contaminated food or water is also a reason. Contact with any jaundiced patient. So what happens? So in past history, you can ask for previous episodes if neonatal jaundice was there, and known hemolytic disorders, though it is not very significant, but it can be there. Family history, so hemolytic anemia and liver disease, and consanguinity of parents before marrying. So we'll go with examination of the child. So examination, first we have general examination. So you have to check for icterus, which is present in sclera, and you can see skin of the child. Uh, Then pallor, that is because of hemolysis. So extremities are pale. You can also check lower palpebral conjunctiva. Then scratch marks. This is because of pruritus and cholestasis. So pruritus is because of uh, involvement of liver pathology, any liver or gallbladder pathology. So that can be because so scratch marks can be because of pruritus. Then you can have edema because it can be there. Ascites can be there because of chronic liver disease. Edema um, because of liver pathology. Then growth failure of the child. Also, we have abdominal examination. So this is very important. Abdominal examination means you can get hepatomegaly, which is most common feature of jaundice. Once it turns conjugated and is gone for more, chronic hepatitis or something like that. Then splenomegaly, it can also be there associated with hepatomegaly. Then ascites, liver tenderness because of acute hepatitis. Then we can have CNS, that is altered sensorium, hepatic encephalopathy. So it is very rare cause. Like it can rarely happen because usually what happens is patients are controlled within the time frame. So it doesn't happen. But if it happens, it's a big problem. Hepatic encephalopathy. So you can have carnictericin because of uh, accumulation of bilirubin. Then investigations. So what are the investigations that you should do as a doctor? So the basic investigations include serum bilirubin. So you have to check total, direct, and indirect bilirubin levels. Then you have to go for liver function tests. So you can go for AST, ALT, ALP, and GGT. Also prothrombin time and international normalized ratio, which is normally 0.8 to 1.2. Then you have CBC, complete blood count. and reticulocyte count to check if the erythropoiesis is happening properly or not, and severe breakdown or G6PD deficiencies and all. Then etiology specific, so you can go for viral markers. So the most common viral markers which you can see if there is any viral pathology. So it is hepatitis A virus, and you can see immunoglobulin M, and hepatitis E virus, you can see again immunoglobulin N. And for hepatitis B, we have HBS antigen. So this is also very important marker because it can be a cause. Then you have to go with peripheral smear. So you can see hemolysis, breakdown of RBCs on peripheral smear. Then ceruloplasmin level. So serum ceruloplasmin level indicate copper toxicity. So that is a major diagnostic criteria for Wilson's disease. Then definitely USG abdomen to check any liver pathology is there, or any gallbladder stones or cholestasis, anything, cholelithiasis. Then liver biopsy if indicated, because it is not a primary thing. If nothing happens, then you have to go for liver biopsy. Then a very important criteria, because most of the Indian doctors, when they pursue their MBBS, they have to work in rural centers as per a rule, and for SRship also as a PG. So there you might find it very difficult for, like, this investigations might take time. Usually it doesn't take time, but when you are in OPD heavy, and you don't have many resources available, this does happen. So what a doctor should know is Kramer's rule. So we have modified Kramer's rule for visual assessment of jaundice. So you can definitely, this is not confirmative, but approximate total serum bilirubin level. So this is from Ghai. So figure is dermal zones for estimation of total serum bilirubin levels. So face and neck. So if you observe that in face and neck, so yellow discoloration of face and neck suggest approximate total serum bilirubin levels of 5 to 7 milligram per deciliter. Whereas yellowing, that is yellowish coloration of chest and upper abdomen, as you can see in the diagram, suggests a TSB of 7 to 9 milligram per deciliter. And also, if it involves lower abdomen and thighs, it can be definitely between 9 to 11 milligram per deciliter, and legs and arms and forearms. So in the image, you can definitely identify those. So it can be 11 to 13 milligram per deciliter, and at the end we have palms and soles, which are definitive, and you can definitely find 13 to 15 milligram per deciliters. So if yellowish discoloration of palms and soles is there, you can definitely say that the patient's serum bilirubin level is more than 13 or 15. Then common pediatric causes. So what are the common pediatric causes? So via age you can definitely identify. So in a toddler, that is 3 years almost, up to 3 years. So it can be viral hepatitis A. Then school going children. So it can be A and E. And hepatitis is the most common usually. Adolescent, so it is hepatitis A, E, and autoimmune hepatitis, which is also nowadays very common. And at any age, it is definitely because of hemolytic anemia. Because it, even if it is not there, there is a chance of getting hemolytic anemia. There is still a possibility. Management. So now we'll go with the management. So how you should manage a child, how you should treat a child. So general management in all children, you should do it. So adequate hydration without getting the investigation. If you don't have any investigation and Kramer's rule suggests that the patient has jaundice and it is very much visible, then you can definitely go with this management first. Then high calorie diet, avoid fasting. So patient has to like avoid fasting. Like you shouldn't fast. Then fat soluble vitamins like A, D, E, K for cholestasis. Then avoid hepatotoxic drugs like paracetamol, ATT, and some herbal medications. Monitor LFTs, liver function tests, prothrombin and international normalized ratio, and bilirubin trend. Then further we have etiology specific management. So in unconjugated jaundice, it is comparatively easier to manage. So we have hemolytic anemia. Treat underlying cause for hemolytic anemia. So you can give folic acid supplementation, blood transfusion if severe anemia is observed. Then you have to avoid oxidant drugs in G6PD. Then Gilbert syndrome. So this is enzyme deficiency, UTP enzyme, UGT1 enzyme. Then you can give reassurance only and no treatment needed because it is slight deficiency of that enzyme. Whereas in Krigler-Najar syndrome, it is some severe deficiency of that enzyme. So we have type 1, which is more severe, and you have to go with liver transplant. And for type 2, we have phenobarbital as a treatment modality. Then further, we have conjugated jaundice. This is more serious compared to unconjugated. So for viral hepatitis, which is most common cause, for hepatitis E and A, you can give supportive care, rest and fluids. Nutrition is also very important, and please avoid fatty foods. Here it is written not mandatory, but please, this is wrong. You should avoid fatty foods in patients with conjugated jaundice, and usually also you should avoid very much fatty food. Then see, though good fats are very nice for body for our hormone regulation, but some some saturated fats are very bad for our body. Then usually it's self-limiting. And hepatitis B, so usually supportive. It is supportive treatment. You can give antivirals only in severe and chronic cases. Then drug-induced hepatitis. So to stop offering the offending drug, supportive care and monitor LFTs. Then obstructive causes, so cholestatic jaundice. So signs are pale stools, dark urine, and pruritus. The three triad of this jaundice, obstructive jaundice. Then the management of obstructive jaundice is fat soluble vitamins. So management of obstructive jaundice is fat soluble vitamins, uh, urodexacolic acid, and surgical correction if it is a structural cause. So biliary atresia also you have to go for surgery. Colorectal cyst also you have to go for a surgery. Then autoimmune hepatitis. So we have steroids like prednisolone, then azathioprine, then pediatric hepatology referrals. So if something happens like this, you have to definitely give general management and most of the common management which you think correct is for that time after investigations. But definitely you have to go for pediatric hepatology referral. Then Wilson's disease. So in Wilson's disease, you can have chelation therapy, that is deep penicillamine and zinc therapy. And sadly, Wilson's disease requires lifelong treatment. Management of complications. So what could be the most common complications in this jaundice? So one is coagulopathy. So if there is any coagulopathy, vitamin K should be administered and fresh frozen plasma if needed. So this is very important. Then encephalopathy is also very important. So you have to give lactulose and ICU care. Lactulose is life-saving drug in encephalopathy. Then pruritus. So pruritus may you could give cholestyramine, and in ascites you should do salt restriction and diuretics should be given for lowering the fluid volume. Thank you everyone. I hope this lecture was very informative. If I made some mistakes, I'm really sorry for that. And if you have any doubts, you can ask in the comment section. Thank you.